Hello, everyone. I hope you're all doing well. My name is Rashida, and I'm the chairperson at SUPTA. Welcome to the fifth week of our teaching series. This week, we're focusing on vascular surgery. Today, I am joined by Luke, who will guide you through major arterial diseases. To introduce Luke, he is a final year at the University of Bristol. To make this session as engaging as possible, we'll be releasing polls throughout. These are completely anonymous, so I encourage you to participate actively. If you have any questions during the session, please pop them in the chat and we'll address them at the end of the session. We'll also share a feedback form at the end. If you complete this, you will receive a certificate of attendance and exclusive discount codes to Teach Me Surgery and pass the MRCS. This session is being recorded. The recording and the slides will be shared on our Medal page as well as our website a couple hours after a session, so please be sure to keep an eye out for that. As you may know, we have launched our very own learning portal, which is hosted on our website. Through this learning portal, you'll get access to practice questions, session recordings, and also revision material. As a bonus, all members will get a discount code to 10% off the Geeky Medics anatomy flashcards, surgical flashcards, and knowledge bundle. Membership is completely free, so be sure to head on to our website after this session to explore this. We also have an exciting opportunity for all of our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards at the Geeky Medics OSCE stations. To enter, simply complete the Google form at the end of the session and enter the unique code we will provide. The more sessions you attend, the higher your chances of winning. So be sure to stay until the end of the session and attend as many of our other sessions as well. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons England, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. Without further ado, I'll now hand it over to Luke.
Hi everyone, thank you for joining. My name is Luke. I'm a final year medical student from the University of Bristol. I integrated in anatomy and I'm actually doing the SFP next year, which is vascular themed. So this is a good opportunity for me to kind of brush over some of the important concepts and conditions. So today we're focusing on major arterial disease, and I'll kind of just give a brief overview of what that will involve. Just a quick thank you to the partners, as Rashida said. So we'll be covering carotid artery disease, aortic dissection, and AAAs. I won't read out the specific learning objectives, but it will basically be looking into the pathophysiology, investigations and kind of management, and looking more into the kind of surgical management and how it's approached and things. So in terms of how the session will run, we'll kind of work top to bottom. So we'll start with carotid artery disease as a concept. We'll then look into endarterectomy and the relevant anatomy to that and the anatomy relevant to carotid artery disease itself. And then we'll kind of cover the anatomy of the entirety of the aorta, so thoracic and abdominal, before moving on to the clinical pathology of aortic dissection and AAAs. I'm losing my voice a bit as well, so I apologise for that. So we'll make a start. So carotid artery disease basically refers to this atherosclerotic process that takes place most commonly in the common and the internal carotid arteries. It's a very similar pathophysiology to coronary artery disease and peripheral arterial disease. And therefore it shares many of the same risk factors. So things such as age, family history, smoking, diabetes, obesity, hypertension, things like that. The reason you get it at this site is due to slightly more turbulent flow at this site due to the bifurcation, due to the carotid sinus where you've got a widening of the artery. So that's why that area is predisposed to getting atherosclerotic buildup. And it's actually responsible for about 10 to 15% of ischemic strokes that we see acutely. Just a quick recap of atherosclerosis itself. So usually begins with some degree of endothelial dysfunction. Over kind of your life, with various lifestyle risk factors, you get a fatty streak that develops, you get an inflammatory response to that. There's migration of some of the smooth muscle from the tunica media to form this kind of fibrous cap. And then that, of course, is at risk of rupturing, which kind of can cause the acute events. So in terms of how carotid artery disease actually presents, the disease itself is usually symptomless, in that you're kind of unaware that you're getting this occlusion. You don't get angina as such with coronary artery disease, where you get kind of pain associated with narrowing of the lumen. Instead, it presents with an acute complication. The two main ones, obviously, are stroke and TIA. And obviously, under TIA, we've got amaurosis fugax, which is this transient painless vision loss. Does anyone know, just type in the chat, clinically, how we might distinguish TIA and stroke? I'll give you 10 seconds or so. Rashid, if you can let me know if anyone comments.
Someone's put duration, as in TIA is a short duration.
Okay, yeah. So pretty much, TIA is classically reversible in that it usually lasts less than 24 hours. I think that's the kind of clinical definition that they run with, meaning that you get some kind of stroke-like symptom that then resolves within 24 hours. A stroke, on the other hand, usually leaves you with some kind of permanent paralysis or disability. So those are the acute presentations. Actually, before I go on to that, in terms of why that happens, as I said, when the plaque, which obviously narrows the lumen, is at risk of rupturing, and that reveals this kind of highly thrombogenic surface to which blood can clot, and that's called a thrombus, where you get occlusion due to blood clotting on a thrombogenic ruptured plaque. An embolus, on the other hand, is when part of that blood clot kind of buds off and shoots down and occludes one of the smaller branches, causing kind of a more regional stroke. So if the first poll question, if we've got a patient who has developed over a long period of time a 100% occlusion to one of their carotid arteries, assuming the other one is patent and that there's not been an acute event, how might we expect this to present? So the poll should be up. And Rashida, if you're able to read me out the answers. Yeah.
So I have 37% going with A. Oh, sorry, it's just changed. 44% going with A, 33% going with B, and 18% going with C.
Okay, and none for D?
Sorry?
None for D?
No.
Okay. So it's kind of a bit of a leading question in that, and sort of a trick question. Basically, the answer is C, and the reason for that is because if you've got an entirely patent contralateral carotid artery, the diseased artery can actually occlude, not cause any symptoms, to the point where you actually get a full occlusion and can be completely asymptomatic. And the reason for that is the circle of Willis. So most people will have a patent, kind of patent communicating arteries within the circle of Willis, allowing kind of compensatory cross perfusion, which actually those communicating vessels get stronger as you get an occlusion on one side in response. So people can present with eventually a 100% occlusion of one of their carotid arteries and actually be symptomless. And in that situation, there's not even much point opening up that artery because it can actually predispose to some of that clot budding off, so they usually leave it. So slight trick question there, but it's, yeah, most of you saying A. I guess if it was causing something, it would be contralateral. So yeah. In terms of some other causes of carotid artery disease, atherosclerosis is kind of the #1 cause, but we do have a few other differentials. So carotid dissection, classically in an exam question, this would be a younger adult. It's actually the most common cause of stroke in young adults. It classically follows some kind of trauma, so strangulation, maybe a car accident where you've got trauma to the neck. And it presents with a unilateral severe neck pain and kind of headache alongside stroke symptoms. So that's how you would distinguish the two. Fibromuscular dysplasia, another differential, obviously a lot rarer than just atherosclerosis. But as you can see in the images, you get this kind of string of beads appearance, which is like a what do you call it? Like a multifocal stenosis, stenotic type picture where you've got hypertrophy of the muscle wall causing this strange pattern, as you can see on the angiogram. It can affect the carotid arteries. Does anyone know the vessel or the artery that it's most likely to affect? There's an artery that it classically affects, and it's kind of plus minus the carotid arteries. If anyone knows, put it in the comments, but if not, I'll tell you. I'll give you 10 seconds. No answers, Rashita?
No, not yet.
Sorry. So apologies if I say it before someone types it. But it classically affects the renal arteries, causing a degree of renal disease, but it can also affect the carotid arteries. And then finally, vasculitis. So the large vessel vasculitis is being giant cell and Takayasu's arteritis. But usually those would present with systemic symptoms. And when you kind of learn all the vasculitises and the different pictures, you'll kind of work out which ones occur when and how it presents. But that's beyond the scope of what we're doing today. So if we move on to the investigations for carotid artery disease, just yes or no, does anyone know if there is a screening program in the UK for carotid artery disease?
Someone said no.
Okay, so very good. So that there isn't a screening program. Instead, it tends to only be investigated following a stroke. So someone will present with a stroke, it will be classified as an ischemic stroke in a specific region. And following investigation and kind of acute treatment, then investigation will follow, basically assessing whether or not they might be an appropriate candidate for endarterectomy. An endarterectomy is the kind of definitive surgical treatment of carotid artery disease that's causing stroke. So our next poll is, what is our investigation of choice? Let's say we've got a patient who's had an acute ischemic stroke. They're now stable, and we want to basically assess whether or not they might be a candidate for a carotid endarterectomy. What is our investigation of choice at this stage?
We have 100% going with CT angiography.
Okay. So initially, the go-to is a duplex ultrasound scan. The reason being is it's non-invasive and gives us enough of an idea of the degree of stenosis to assess whether or not they'd be an appropriate candidate. And we'll come on to the specific kind of guidelines, the threshold for carotid endarterectomy. But initially, we want a duplex ultrasound is carried out. Angiography is important and is done before surgery, but usually only in those who we are planning on operating on. So duplex ultrasound is kind of like a screening tool for those who might be a candidate following a stroke. So yeah, and that's stroke or TIA as well. So as you guys said, after that, so once we know that a patient could be a candidate for endarterectomy and we're considering for surgery, then a CT angiogram can be used to further classify the degree of stenosis, where that stenosis is, and how to kind of surgically plan. And we can actually classify radiologically by degree of stenosis. So you can actually have up to 50% of your lumen lost, if you like, and still be classified as mild carotid artery disease, and all the way up to total occlusion, which is obviously 100%. So in terms of the indications, often in reality, it will be a consultant-led decision. It'll be based on the consultant's experience, it'll be based on the patient's comorbidities, patient's preference as well, because obviously it is an invasive procedure. There are risks associated. But in terms of the guidelines, in terms of which patients would we say that the benefit outweighs the risk, it would be those that satisfy kind of all three of these criteria. So they've had a non-disabling stroke or TIA, which basically means there's tissue to save. it's worthwhile doing this because there is tissue to save. It's in the stroke or TIA is in the carotid region. In other words, the stroke or TIA they've had is a result of their carotid artery disease. For example, if it's on the other side, then you'd be thinking, well, the endarterectomy isn't going to really help with that problem. And then the degree of stenosis, some say more than 70%, some say more than 50%. I would probably go with 50% if it was in an exam, for example. But there's no one definitive minimum. It varies. But those are the three important criteria. So all of those need to be satisfied in order for us to deem that patient suitable for endarterectomy. And in terms of when we want to do it, so classically it's within 2 weeks of symptoms. It was shown that I think risk of future stroke is halved if you can do a carotid endarterectomy within 2 weeks of their initial stroke symptoms. And the procedure itself involves removal of both the atheroma and the damaged intima to ensure that it doesn't just happen again. There are various tools that can be used to assess for risk of future stroke, but the one that kind of came up was the Oxford Vascular Carotid Stenosis Risk Score to kind of assess that future risk. Now moving on to some anatomy. So if we start with kind of from a endarterectomy point of view, where are we going? Where is the carotid artery? So there are two main triangles of the neck, the anterior and the posterior. With the anterior triangle of the neck, our borders are, as you can see, so we've got the posterior border being the anterior border of the sternocleidomastoid. The superior border is the inferior border of the mandible, and then our kind of medial border is the midline of the neck. So obviously you've got one on each side. Within the anterior border, anterior triangle of the neck, there are 4 sub-triangles or 4 smaller triangles anatomically, but the one we're interested in is the carotid triangle. And this is where you're likely to find obviously the carotid artery and where it bifurcates. And this has, to remember, borders. So anteriorly, it's defined by the superior belly of the omohyoid. The omohyoid being one of the infrahyoid muscles, so it attaches to the hyoid bone and kind of anchors that bone down during things like swallowing. The posterior border is the same as before, so it's just the anterior border of the sternocleidomastoid, and the superior border is formed from the stylohyoid and the posterior belly of digastric. Both of those are suprahyoid muscles which attach to the hyoid bone and then elevate it during swallowing. And if we look at a diagram where we can see the carotid artery, I've drawn the borders of the triangle there in black, but you can see the bifurcation of the common carotid and the internal carotid. And if you're feeling on yourself, roughly you can go between the larynx and the sternocleidomastoid. So when you're confirming a death or anything like that, that's where you're feeling kind of surface anatomy. That's where you're going to feel for the carotid pulse. Then if we go from, in terms of the artery, the course of the artery, it obviously starts at the aortic arch. We've got that asymmetrical branching pattern in that the first branch being the brachiocephalic trunk, splitting into right common carotid and right subclavian, and then we've got left common carotid and left subclavian branching directly from the aortic arch. Then if we follow the course of the common carotid artery, it basically ascends right up through the neck. It's surrounded by carotid sheath all the way up to the carotid foramen, which is a small hole at the base of the skull that it passes through to get into the brain. The bifurcation point is at C4, which is also the upper border of the thyroid cartilage, which you can feel on yourself. So that's the kind of anatomical landmark we're looking for. And if we kind of zoom in on the bifurcation, there's a lot of interesting anatomy that's important to be aware of when we're going to kind of poke around and cut in that area. So obviously the bifurcation gives rise to internal and external carotids. Firstly, we've got the carotid sinus, which Rashida, can you see my mouse?
Yes, we can.
Yeah, okay. So this kind of bulging at the start of the internal carotid is your carotid sinus. And that's very important it kind of contains lots of baroreceptors. So important in regulating blood pressure and heart rate. The origin of your internal carotid artery is basically the gateway to all blood flowing to the brain. So it's important that you've got receptors there that allow regulation of things like blood pressure. The carotid body, which is labeled here as well, contains various chemoreceptors to regulate levels of carbon dioxide and oxygen in the blood as well. And communication from this area to the brain is via the glossopharyngeal nerve or cranial nerve 9. So that's obviously an important part of the regulation process, feeding it back to the brain. And we've got a lot of important structures that, as much as possible, we'd like to preserve when we're doing any operation on the artery. And just kind of looking from a cross-sectional point of view, we can see here the carotid sheath. So it's kind of this connective tissue that contains three very important structures. It runs from the base of the skull around the carotid foramen inferiorly. And this contains, laterally, we've got the internal jugular vein. Medially, we've got initially the common carotid, and then the internal carotid as it branches, and then posteriorly the vena nerve. And right the way through its course, it's running posterior to the sternocleidomastoid muscle. In terms of the order of these, I guess it's a protective mechanism that the veins laterally close to the surface and the arteries deeper, so that's how I like to remember it, and then the vagus nerve just behind them. Yeah. So I don't even know if I scrubbed, but I've seen 2 endarterectomies on placement, and both times I was quizzed on the anatomy of the branches of the external carotid artery. So I've kind of given it away, but the mnemonic we used, that we were taught when I did anatomy and by those surgeons, was some anatomists like freaking out poor medical students. So it's a really handy way of remembering what those branches are, because it's a fun question for surgeons to ask you. So we're kind of running from proximal to distal, but as you can see, superior thyroid, ascending pharyngeal. I'll kind of go through them. The important thing here is to remember they're named after what they're supplying. So superior thyroid to the thyroid, ascending pharyngeal is running posteriorly towards the pharynx, lingual artery towards the tongue. The facial artery you can feel on the outside of the mandible. It runs to supply the inferior part of the face. You've got the occipital artery towards the occiput, posterior auricular behind the ear, the maxillary to the maxilla, and then superficial temporal kind of continues superiorly. So moving on to the course of the internal carotid artery, it enters the base of the skull through the carotid foramen, and it's actually split into 7 parts by anatomists because it has such a complex course. So I'll quickly run through them. It's not important to kind of know it in a lot of detail. But C2 is entering the carotid canal. It ascends superiorly. I'm hoping you can see my mouse. It then runs anteromedially towards the petrolingual ligament, which is defined as C3 as it runs through that. C4 is very important because that's where it runs through the cavernous sinus. So if you can remember anatomy of some of the venous structures of the inside the skull, the cavernous sinus kind of sits on the base at the front, one on each side, and the artery literally runs through that venous sinus alongside various other important nerves. C5 is it passing through the dura mater, so you've got these 2 gold rings is proximal and distal dural ring, and then C6 is where it gives up its first branch, which is the ophthalmic artery, and C7 is it continuing and then contributing to the circle of Willis, which will then quickly try and cover. So the black circle is where we're up to, so that's where it starts to form the circle of Willis. The internal carotid artery continues itself as the middle cerebral artery. The other other cerebral arteries being the anterior and the posterior that are supplying the area that they're named after. The anterior communicating artery, again, allowing some of that cross perfusion if there's compensation that's required. The basilar artery, again, completing this circle. And then the vertebral artery, which is, again, another way in which the brain is supplied. 2 other important arteries aren't named here are the anterior inferior cerebellar artery, which is this one here, and then the pica or the posterior inferior cerebellar artery, which is this one here. And those are associated with specific stroke syndromes. I think it's Wallenberg's or something for the pica, and then lateral pontine or something for the anterior inferior. But you'll kind of learn those clinically as you cover stroke and things. But basically, you've got this very complex arterial structure that actually has cross perfusion and maintains perfusion of the brain, even if you've got compromise from one of the supplying arteries. So kind of important to learn. Maybe not for exams, but it's a very important anatomical structure. So moving on to the endarterectomy itself, just a quick overview. Incision is via the anterior border of the sternocleidomastoid, so that's where incision into the skin takes place. We then are clamping the internal carotid artery and the common carotid, and often a shunt is placed to allow for continual perfusion, although it's not 100% necessary, as obviously you've got perfusion from the contralateral carotid artery. We're then incising longitudinally, allowing removal of the atheroma and the damaged intima, and then often it's closed with a patch to complete the surgery. That's obviously a simplification. It's a lot more complicated than that, but that's essentially the plan. So, unless there are any questions about that section, Rashita?
No, there aren't any in the chat yet.
All right. So we'll move on to aortic disease. So this will be split into aortic dissection and abdominal aortic aneurysm, or AAA. But we'll start with the anatomy because it works a bit better that way around in this case. So the aortic arch itself starts and ends at T4-5, which is an important anatomical landmark. It's the level of the sternal angle. It's the level of bifurcation of the trachea. It's kind of the superior limit of the pericardium. So that's where it starts and ends. Technically speaking, the first branches are the right and left coronary arteries, which are just above the aortic valve. And then, as we've discussed before, the three branches of the aortic arc can be seen here. And this, again, is ascending aorta, descending aorta. There's kind of a bit of a overlap of when it becomes ascending, when it becomes arch, and then when it becomes descending thoracic aorta. In terms of branches from the descending thoracic aorta, you have your posterior intercostal arteries arising from that, which aren't shown here. And then the descending thoracic aorta enters the abdomen through the aortic hiatus of the diaphragm at T12. The way I remember the entry, which I'm sure you've got your own ways, but aortic hiatus has 12 letters, esophagus has 10 letters, so that's T10, and then vena cava has 8 letters, and that goes through at T8. Then moving on, so the branching anatomy of the abdominal aorta is slightly more difficult to remember. So it descends on the left of the inferior vena cava and the vertebral column, so slightly to the left of the midline. Our anterior branches, which are very important with gut anatomy and things, are the celiac trunk at T12, the SMA at L1, and the IMA at L3. Our lateral branches, you've got the middle suprarenal, which is just above the renal artery, but more importantly, the renal artery at L1, and gonadal arteries at L2 either side, so that would be your ovarian or your testicular artery. And then dorsally, you've got your inferior phrenic, you can't see on this image, but that's supplying the posterior region of the diaphragm. Your lumbar arteries from L1 to L4, and then median sacral artery, which basically comes down right here at the bifurcation, and it bifurcates at L4, another important vertebral level. Before I move on, does anyone know any of the branches of the celiac trunk? Just name any of them if you know any of them in the chat.
Someone's mentioned left gastric artery.
Say that again, the left gastric.
Yeah.
Yeah. Good. That's one of them. Any others?
We have the splenic artery and the common hepatic as well.
Perfect. So those are the three. Well done. And they're obviously supplying what they say they're supplying. So those are the three branches. Again, a common anatomy question. If you're in theatre and there's anything related to this artery, they'll probably ask that. So good to know. So our next poll question, moving on to some of the pathophysiology, sort of the pathology of the aorta. Which of the following best describes aortic dissection? I'll give you a moment to vote.
%, have gone with B.
Perfect. So yeah, that's the correct answer. Well done. I tried to trick you out here. This is aneurysm. Sorry, no, this is rupture. This is aneurysm. But yeah, well done. So to show you what that looks like, as I'm sure you're aware, you get a tear in the intima, which allows creation of this false lumen, which fills with blood and ultimately clots. And the risks of that are, firstly, it can rupture. You've then got a massive internal bleed that's very difficult to get under control. It can also, this clotted blood can occlude some of the branch arteries coming off it, because it kind of squeezes them from the outside. So it can cause ischemia as well. So those are kind of two important complications that can ultimately lead to death in this case. And I believe mortality is about 20% before you even reach hospital in cases of aortic dissection. So yeah, an important condition to know about. In terms of the classification, the most common is the Stanford classification. Type A, defined by involvement of ascending aorta or aortic arch, and type B being descending from the descending thoracic aorta, so not involving the arch. The reason for this classification is to guide management. So on the whole, we can manage these two scenarios differently based on where they are. But again, a common exam question would be what kind of classification of aortic dissection is this? So yeah, help stratify risk complications and therefore guide management. So the DeBakey system is similar, in which you've got three types and they kind of overlap, as you can see. In terms of some of our risk factors, does anyone know the most important risk factor for aortic dissection? I'm quoting Teach Me Surgery by saying most important, but there's kind of one classic risk factor that we worry about.
Someone's mentioned Marfan's.
Okay, so Marfan's is a really good one and classic exam one. However, it's probably not the most common as well. So I guess important is a vague term. So I should be more clear. The classic one, the one that's most common, and there's a direct correlation, is hypertension, in which you've a higher exertion from the blood on the walls of the aorta, particularly over a long period of time, so over decades, that weakens the integrity of the intima and the soft tissue behind it, allowing for dissection. But other modifiable risk factors are trauma. So one that I think I saw in the exam question was someone wearing a seatbelt and then there's a car accident and then they've got some kind of compressional trauma on the aorta and it dissects. Smoking and cocaine are two classic ones, and then syphilis is a tertiary feature of syphilis, a bit of a niche thing that might come up in the exam. And then non-modifiable risk factors, so yeah, Marfan syndrome, Ehlers-Danlos loss, the connective tissue diseases, in which you've got some degree of structural, I guess, weakness in the soft tissue of the aorta, which predisposes it to dissection. A bicuspid aortic valve is associated with aortic dissection. And finally, genetic syndromes, Turner's and Noonan's are the two classic ones that have that association. In terms of presentation, there's the classic textbook presentation, which is a man over 50 years old presenting with sharp tearing chest pain radiating through to the back, and that pain is often maximal on onset. Presentations won't always look exactly like that, but that is a fairly typical way in which it presents. In terms of the signs, it presents with hypertension, assuming it hasn't ruptured. You often get a weak or absent carotid, brachial, or femoral pulse, radioradial or radiofemoral delay, which both of those, the last two, occur due to compression, the dissection compressing various branching vessels, resulting in a delay in pulse or just weak pulses in general. And the same for the variation in systolic blood pressure by more than 20. You've got an occlusion of one side, an asymmetric occlusion of blood flow to one arm compared to the other. So those are the classic signs of aortic dissection. In terms of complications, so I did kind of briefly talk about them. One important one being propagation of dissection. So when that dissection compresses on branch vessels, it can cause ischemia. So the areas of ischemia are the coronary arteries. If you've got a dissection that kind of moves backwards, compressing the coronary arteries. Often you can get ECG changes with that, although apparently it's uncommon. And again, angina, difficult to distinguish between that and the tearing pain you're getting anyway. But that is a hugely important complication to look out for, and that's why they're put on cardiac monitoring in this case. Spinal arteries, again, small branch vessels of the aorta, and that can result in a degree of paraplegia. And then distally, if you've got an occlusion of a branch vessel, that can affect the bowel and cause bowel limb ischemia as well. So in terms of assessing someone with aortic dissection, as with any acutely unwell patient, we'd run through an A to E assessment, and that would involve kind of the normal A to E steps. But in terms of investigations, 3 common investigations that we might do on someone with this presentation are a chest X-ray, which can be helpful for ruling out differentials such as pneumothorax, maybe a pneumonia. An ECG, again, looking for potentially cardiac changes if there's a retrograde dissection, and bloods as well. And I'll kind of speak specifically about which bloods in a second. But in terms of the chest X-ray, can anyone see this is a patient with, let's say, a 6-year-old guy presenting with severe chest pain radiated to the back? What abnormality can we see in this X-ray? There's something that looks off.
Someone's mentioned hypertension and someone else has mentioned aorta.
Okay. Was the hypertension one just now, or was that in response to a question before?
Oh, actually, it was before. Sorry, it's just loaded up for me. For now, someone's just mentioned aorta.
Yeah, okay. So there's a widened aorta. So this is where you'd see the aortic knuckle, which is part of the arch, which might be here. You can see my mouse. But this is a very clearly widened mediastinum. It's almost as wide as the heart. So this should be a lot narrower. And this is what you would see in like a type A dissection, where you've got this dissection, this false lumen that expands the diameter of the aorta, and then that can present on an X-ray. So that's another reason you might do a chest X-ray. But obviously, it all depends on if they're stable or not, and whether or not they can actually undergo that. So again, you might see widened mediastinum on chest X-ray. ECG, classically normal, but you might see some inferior lead ST elevation if we've got the right coronary artery occluded. With bloods, a range of bloods you would do in a patient with this presentation, but the 3 important ones that are easily forgotten that we need to do are troponin, again looking for coronary artery ischemia. D-dimer, you've got the classic thing, you do a D-dimer for a VTE, for like a PE or a DVT. In this case, you've got clotting on like a large scale, you've got exposed thrombogenic tunica media, and therefore D-dimer is likely to be raised. And then finally, cross-match and group and save, basically looking at what's their blood type. We're likely to need to infuse them, they're likely to need surgery, so we need to get a cross-match and a group and save in patients with likely dissection. In terms of immediate management, in this case, I guess by now it'd be fairly obvious that you've got potentially an aortic dissection, so you'd call the relevant people. In terms of how it's immediately managed, things we can do acutely. So cardiac monitoring, as I mentioned, just to ensure we're not getting ischemic changes, but it's important that we get their blood pressure controlled. So often they'll present with a hypertension. We want it between 100 and 120 systolic to ensure that we're not getting any propagation of the dissection, and we're reducing the risk of rupture as well. And IV labetalol is the beta blocker that tends to be given to drop that blood pressure to around 100 to 120. Usually you don't like to just drop blood pressure that much for no reason. If someone's just got a hypertension that's say 200 over 120, you're unlikely to just give IV labetalol unless you've got something like this, where we actually care more about reducing propagation of this disease than things like underperfusing the brain slightly. So in terms of what we do at this point, obviously, if we're, depending on who we are, at some point, we're going to want to call vascular surgery. We may or may not have done the gold standard investigation, which I'll come on to in a second. But at some point, when suspicion is there, we call for vascular. So what is our gold standard investigation for a potential or suspected aortic dissection? I think it's a poll. So
Okay, so we have 11% going with A, 22% going with B, 44% going with C, and 22% going with D.
Okay, so it's a nice broad range of answers, which is probably a good thing. It means we're testing something that isn't necessarily obvious. So the answer is a CT aortogram, which is basically a CT scan of the aorta, often involving a contrast. And it will become apparent why contrast is used when I show you a typical scan. Does anyone know the sign we're looking for? Or we're looking for something on that scan that's indicative? If not, that's okay. So,
yeah, we don't have any responses in the chat, unfortunately.
Okay. So this is a CT aortogram of someone with an aortic dissection, and the sign we're looking for is something called a false lumen, which I spoke about what that looks like anatomically, but that's the name of the sign, which makes sense. So to some of you that might be obvious what I'm talking about. We've got the heart here. Maybe I assume you can see my mouse, and then we've got the aorta. So we've clearly got two separate regions here. We've got this part A and B. Just maybe this should have been a poll, but which do we think is the false lumen? If you can just put an answer A or B. You might be able to work it out even if you don't know.
Someone's put B.
Okay.
We're getting a lot of B, yeah.
A lot of B.
Yeah.
That's good news. So yeah, B is the false lumen. The way I tell is we've given them a contrast. The blood obviously has fresh blood. Sorry, the heart has fresh blood in it, and therefore this is the fresh moving blood. The darker area is likely clotted blood that was probably there before we even gave them the contrast, and therefore we can see a clear flare of clotted blood within it. So that's fairly that is the gold standard diagnosis for aortic dissection. However, that assumes that they are hemodynamically stable and that we've got enough time to put contrast in them and get them to a CT scanner. If not, often they might do a transesophageal echo, which is an echocardiogram that goes into the esophagus, allowing us mainly to look at the heart because of their anatomical proximity. But we're looking for complications or signs associated with dissection in the heart. So pericardial effusion, aortic valve involvement or regurgitation, fairly common associated symptoms, I guess, with a dissection, especially if it's a type A where you've got aortic arch involvement. And that's kind of as an interim before we take them to theatre. If they're hemodynamically unstable and they're in shock, we need to get them to theatre as soon as possible. In terms of management, so this is where the classification becomes important. So with the type A, we need to be managed surgically, and that goes to cardiothoracics who are used to opening people's chests up and filling around with the heart and the aorta. And then type B would be more conservative, classically. That would be the vascular team looking after that. And they may be suitable for endovascular repair, but it will depend on the specific situation. In terms of the surgical repair, this is called an aortic arch replacement, where they basically take out the dissection or the dissected region, ensuring that it can't propagate any further, and they replace it with this synthetic material. And this elephant trunk is like an endovascular portion that again prevents exertional pressure on the walls of the aorta. Usually a median stenotomy. It's a procedure that requires cardiopulmonary bypass, which is like a heart-lung machine to keep oxygenated blood pumping around the body while you stop the heart and operate on the major vessels. And it also often involves antegrade cerebral perfusion, which alongside cardiopulmonary bypass allows for perfusion of the carotids to ensure that the brain's being perfused. There are obviously a variety of specific replacement techniques, and it will depend on the specific anatomy of the dissection and the patient anatomy. Things like aortic arc variation can play into that as well. Cool. So moving on to AAAs. So this is one of the answers of the previous poll question, but it describes a dilation of all three layers of the abdominal aortic wall caused by degenerative disease, usually between L1 and L3, so between renal arteries and the IMA, as you can see in this image here. And it's defined as an AA diameter of more than 3 centimeters. That's the cutoff point that's used in screening. And that's the cutoff point that's basically used to define the condition. And some statistics to show you that it is a fairly prevalent issue. 1 in 70 men over 65 have a AAA, which if you think about the total population in the UK, that's going to be a lot of patients. And there are over 3,000 deaths per year from a ruptured AAA in the UK, which kind of highlights why there is a screening program for this condition. In terms of the risk factors, as it's a degenerative arterial disease, a lot of the cardiovascular risk factors apply. However, interestingly enough, from kind of all the research that's out there, evidence points towards diabetes being protective against this condition. The same actually goes for dissection. And I think from what I was reading, people are kind of puzzled as to why that is. There's no known reason for it, but evidence points towards diabetes actually being protective. Other triggers include infection, the same connective tissue diseases as before, trauma, and then again large vessel vasculitis such as Takayasu's arteritis. In terms of how AAA can present, so the most common presentation is just that it's asymptomatic. So most people with a AAA just won't have any symptoms. Again, that's why there's a screening program in place. It can be symptomatic unruptured, in which they may have had kind of ongoing abdominal, back, or loin pain. On examination, you might see that expansile abdominal mass, and then it can cause distal embolism, such as limb or bowel ischemia, where you get, due to turbulent blood flow in the region of aneurysm, you can get clots forming, and that they can kind of go off and form emboluses in more distal branches. And then finally, it can present as a ruptured aneurysm, in which case more severe acute abdominal, back, or loin pain. Again, the same expansile abdominal mass, and then shock as well is the defining presentation feature that makes us consider that it might be ruptured. Yeah, I think this is the last poll. But what's the screening program in the UK for AAAs?
So we have 45% going with A, 18% with B, 18% with C, and 18% with D.
Okay, so again, mixed response. I always find the screening programs are very difficult to remember, especially as a med student. You've got to learn all the screening programs for all the cancers. AAAs, the answer is actually D. So all males are invited for screening just one time at the age of 65. So as a man, when you turn 65, you're invited for AAA screening, which is done so with an abdominal ultrasound scan, and then your risk stratified based on the diameter of your abdominal aorta. So again, less than 3 centimeters, we're saying clinically they haven't got an aneurysm, and therefore no further action required. We've then got cutoff points for rescanning. So if they're between 3 and 4.4 centimeters, then we rescan every 12 months. 4.4 to 5.4, then every 3 months. In both those groups, if we're rescanning them, we're saying they've got an aneurysm, and therefore we want to kind of target some of those cardiovascular risk factors in the meantime, and try and reduce those and any chance of it expanding. And then if they're 5.5 centimeters or larger, then they meet the criteria for a referral within 2 weeks to vascular surgery. And that's with the view of kind of intervention. So for those who have a high risk AAA, which is defined as more than 5.5 centimeters, but also growth by more than 1 centimeter per year, or if they've just got a symptomatic AAA. So if they've got any of those features, then they're deemed high risk, and therefore often seen by vascular surgery fairly urgently to decide whether they're best suited for endovascular approach or an EVAR or surgical approach. An EVAR is less invasive and has better short-term outcomes, so referred in older, slightly more frail patients. If you're younger or you're fitter, then due to the better long-term outcomes of surgical AAA repair, that might be the preferred option. Just quickly going to go overview those two procedures. So an EVAR, fairly common procedure in vascular surgery, involves stenting the abdominal aorta and parts of the common iliac arteries with entry via the femoral artery. By doing so, you prevent continual exertional outward pressure on the aneurysm, reducing risk of rupture, reducing the risk of it growing, and basically protecting the aorta from the inside. And that's you get this trouser leg looking graft that ensures it stays in place as well. However, with such a procedure, although there are better short-term outcomes, the common complication is something called an endoleak, which is basically where you get, despite having put that graft in, you get continual filling of the aneurysm due to some kind of leakage. So that varies from 1 to 5. 1, it's kind of leaking because there's a poor seal. 2, there's a branch vessel that's allowing blood flow. 3, there's just leaking through a defect in the graft. 4, it's leaking through pores in the graft. And then 5, there's an expansion without any known leak. Usually that can be fixed with a minimally invasive endovascular procedure, but sometimes it needs open surgery to repair. In terms of the surgical repair, it's a midline laparotomy to get to the aorta. Whenever you're in surgery and they're doing a laparotomy or any abdominal surgery, they classically like to ask the layers of the abdominal wall. So it's good to learn. So that's skin. You've got the 2 layers of fascia. So Camper's is like a fatty fascia that overlies Scarpa's fascia, which is more of a membranous fascia. You've then got your muscular layer, so it depends where you're going in. If you're going in centrally, you've got the rectus abdominis. Laterally, you've got the external obliques. Beyond the muscular layer, you've got the transversalis fascia, which lines the inside layer of the muscle. And then you've got extraperitoneal fat and tissue before the parietal peritoneum. The parietal peritoneum isn't necessarily cut. It can be preserved and kind of pushed out the way to get to the aorta via kind of retroperitoneal access, but also it can be cut and just move the organs out the way. This is a view, so it's often very obvious. This is midline laparotomy, which you can see this bulge here being the abdominal aorta, the aneurysm, and yeah, everything's kind of moved out the way, and then it's carefully repaired. It is clamped either end to prevent blood flow, and then the segment is removed and replaced with a prosthesis, as shown. Often the arterial wall is then sewn back over for whatever reason. I'm not sure why, but they like to do that as well. But this is, again, better long-term outcomes than EVAR. In terms of just the final thing of this session is looking at ruptured AAAs. So again, presenting acutely, you get more severe back and abdominal pain, but often presenting with shock. So things like syncope, they might have passed out, hemodynamic instability, hypotension, and again, that pulsatile tender abdominal mass. The majority rupture posteriorly into the retroperitoneal space. You might imagine it kind of going anteriorly, but the majority are retroperitoneal, and 20%, only 20% rupture forward into the peritoneal cavity, and those have a higher mortality. In terms of management, assessment is going to be the same. We're doing an A2E assessment, same sort of bloods, baseline investigations. Again, we would like to aim to keep the blood pressure fairly low, but it likely already will be as they're in shock, so less of an issue. And then they need urgent transfer to a vascular centre for either immediate open repair if they're unstable with it, and if they're stable, often they'll do a CT angio to dictate which option's better, so EVAR or open. There's a recent study, the IMPROVE study, found mortality rates similar between the two for a ruptured AAA, but non-mortality outcomes, which I believe will cost and shorter hospital stay with an EVAR. So it's superior in that aspect, but similar with regards to mortality. So thank you all for listening. I apologise if that was fairly quick. a fairly quick run through. So if you do have any questions, feel free to email me. But thank you very much all for listening. And if there are any questions now, Rashita, let me know. Otherwise, I'll pass back to you.
There are no questions in the chat for us. I think Bianca is going to come on and actually close the session. Bianca, will you be able to do that?
Hiya. Sorry, it just took some time to connect. Thank you so much, Luke, for running this incredible session. I learned lots from it, and I hope everyone did too. So the feedback form should be in the chat, and remember to fill it out to get your certificates and your discount codes for things like Teach Me Surgery and Pass the MRCS. Make sure you also complete the Google form that we've linked above that, so you can get a chance to access the Geeky Medic surgical flashcards and OSCE stations. We'll also be posting the single best answers to our socials for additional practice, so keep an eye out for that. We've linked those all in the chat, and you'll find a resource bank with all the materials. Be sure to keep up with our socials for details on the next session and all the resources we have available. Thank you so much for joining us, and we're looking forward to seeing you guys at the next session, which is on limb ischemia. Rishta, do you want to add anything?
No, that's it. We hope to see you all tomorrow. Thank you, everyone. Bye.